words, how much blood the heart puts out. So that's the way the body determines blood pressure. That's the way we determine blood pressure. We can reduce volume, or we can reduce the resistance. This is why ACE inhibitors are such a great medication. This is why so many people get ACE inhibitors. And ACE stands for, anybody familiar with the renin-angiotensin system? Yes? No? Yes? No? Yes? No? 99. Here's the idea. Remember our aorta coming out of the ventricle, shooting blood out at just under 200 miles per hour. The first openings that it shoots past coronary arteries, and of course it goes up to the arteries that are going to go to the brain or go eventually to the brain. And then it arches over, goes down through the thoracic cavity and the abdominal cavity, branches off into two big arteries which go into the kidneys. As the blood is going into the kidneys, at the level of the glomerulus, at the level of the filtration area, there are specialized cells called juxtaglomerular cells. You may have heard of this before, but you might not remember it. The juxtaglomerular cells are pressure-sensitive cells. They can sense when the pressure is low. So if they believe that the pressure is low, they release something called renin. Renin then goes out to activate angiotensinogen. Angiotensinogen is then converted to angiotensin 1. Angiotensin 1 goes to the lungs, where it is converted to angiotensin 2 using the angiotensin converting enzyme, ACE. And then angiotensin 2 goes out and does a couple of things. First thing it does, most importantly, is that it increases peripheral resistance, which means the blood that was flowing through the tubes that were this big, that same blood is now flowing through tubes that's this big. So now we're going to increase the pressure, right? You know that. You decrease the radius, you're going to increase the pressure. That's the first thing it does. Then it activates aldosterone. Aldosterone in the endocrine system, of course, is going to cause sodium to be reabsorbed back into the blood. And if sodium goes into the blood, what follows salt? Water. And that is going to increase blood volume, which is going to increase blood pressure. And then it also activates, or acts on, I should say, ADH, antidiuretic hormone. So it will allow more water, it'll open up the water channels and allow more water to come back into the blood rather than being lost into the urine, which is going to increase volume, therefore increase pressure. This is why angiotensin converting enzyme inhibitors, or ACE inhibitors, are so frequently used, because they do a really great job all around. And of course, by blocking that conversion of angiotensin 1 to angiotensin 2 in the lungs, it causes this buildup. And that causes an irritation, which is why these patients always complain of that dry cough that they can never seem to shake. Something like cynical, right? So if we want to change blood pressure, we can change the total peripheral resistance, or we can change the cardiac output. Does that make sense? Change the volume. And that doesn't just mean peripheral volume. It means how much the heart is going to pump out. We can also alter how much the heart is going to pump out by blocking certain receptors that will decrease contractility, excuse me. Let's see what we do. Calcium channel blockers decrease contractility, so it doesn't have that force it's going to pump blood out with. Beta blockers work similarly. But they do get much more complicated because each one of those classes also does other things. All right, so that's why all the medications that we give are going to affect, in one way or the other, either cardiac output or total peripheral resistance, because that's what our body is. Makes sense? Primary hypertension, essential hypertension, we don't know what causes it, but we know what will happen if we don't fix it. So that's why we give those medications. That's why we ask patients to alter their lifestyle. Secondary hypertension, what causes that?
Lifestyle.
Whatever causes the hypertension, what could be an example? Diabetes. Not so much diabetes itself, but diabetes can alter kidney function, causing kidney failure. And if one kidney is not getting perfused well enough, it will think that there's a problem and it will start sending out rennet. How about something like a tumor? We talked about pheochromocytomas, I think. Pheochromocytomas. Sorry? Well, it could, but it's also going to have the same effect of lowering blood pressure by losing volume. But it can increase peripheral resistance. Atherosclerosis, arteriosclerosis. Of course it will, but why does that particularly cause the blood pressure change? Because that's something that we can't necessarily alter. You know, most of the secondary hypertension, we can change something. If we can fix that kidney or get rid of that kidney, or if we can get rid of that tumor and fix the bleed, we can reverse that back to normal blood pressure.
Doesn't that change your restriction?
Changes all of us, because we all have it. It's something that just occurs naturally as you get older. And it doesn't mean older mean like 60 or 70. I mean older from your 20s on. There's atherosclerotic plaques. Now they're not terribly prevalent, but they're there. And there's other types of arteriosclerosis that will come from that. And of course, atherosclerotic plaques coming from lipids, coming from cholesterol. So we know that we need cholesterol, so we can't get rid of it completely. Just make the body stop making so much. And that will help control it, but it won't fix it.
Would it be secondary if it was just stuff that you ate on a regular basis? Like
well, when we talk about these hypertensions, I'm talking about chronic, persistent hypertensions. Because there's other hypertensions, like white coat hypertension. You're familiar with this?
You go to the doctor and your blood pressure goes up?
Yes. You go see a doctor and your blood pressure goes up.
Mine goes down.
Yours goes down. I'm so calm. This is awesome. Nothing better than magazines that are 6 months old. Knowing I'm surrounded by a whole bunch of other sick people. That is comforting. Oh, and a copay. Don't forget that. I have no idea.
Depends on your insurance plan.
What if you don't have insurance? That's a bigger problem. They just don't care. They just don't pay anyway. Can we get back to blood pressure? Just for a little bit. What's low blood pressure? Persistently low blood pressure would be a reading of what? Hypotension. Persistent reading of what?
Under 110 over 70.
Lower than that. No, that's
Is it?
110 over 70, that's good. I'll take that.
Is it?
Yeah, if you're giving that away, I'll take it. Less than 90 over 60. Less than 90 over 60, persistent. Yeah, and that's when you're going to see, you'll see that. Those anorexic women, those ones who never eat. And, well, they do eat. They eat a spoonful of peanut butter and a Diet Coke for their meal. And of course, they're always going to complain about being cold, right? Of course, they're going to be cold. They're not having infusion. What are we going to give them? What are we going to tell them to eat more of? Salt. See, you heard, listen. I'm a good teacher.
So go to the bar and get get a drink and a whole
You're
bunch of
listening
peanuts.
incorrectly.
You're listening at the wrong times.
You are.
We did talk about
We
that.
did, I know. What is the normal blood pressure?
120 over 80.
For years and years and years, it was 120 over 80, right?
110 over 70.
However, that number has changed. The most accepted version is less than 120 over 80, although some books will print 115 over 70 or some alternate in-between number. So the problem with that is, by lowering that number, we also lower the pre-hypertension numbers, which means now we lower the hypertension numbers, which means we took categories of people who were designated pre-hypertensive, and we've just put them into the hypertensive category. So that's unfortunate. But the good news is, hopefully, it will get people to target a lower number, and that's always a problem. You know, if you tell somebody to do 55 miles per hour, how fast are we going on the freeway? How fast do they go on the freeway?
90.
85, right. So if you tell them to, if you lower that number a little bit, that kind of helps.
Take out a train stoplight.
Ah. Oh, there it is. Cardiac output is equal to heart rate times stroke. And mean arterial pressure is up there. Okay, blood pressure. Mean arterial pressure is equal to cardiac output times total peripheral resistance.
That blood pressure, is that mean arterial? What is that?
Yeah. That's just what they're designated.
I guess we're not doing that now.
Yeah. Heart rate, stroke volume, regulated by autonomic nervous system, but you know that because you don't have to think about it. Sympathetic division can release neurotransmitters, increase heart rate, and force the contraction. Inotropism. Inotropism just means something has interfered with the change of heart rate. It doesn't necessarily mean higher, it just means different. Peripheral resistance is just about, it's about diameter, it's about closing off gates, it's about at the capillary level, the pre-capillary level, actually. Letting blood flow through the capillaries or not letting blood flow through the capillaries. We have these little sphincters that can alter that. So of course, that is going to cause less blood flow through, that's going to increase resistance. Okay, you need to know about shock, right? Does anybody not know about shock? Okay. Not enough flow. Cardiogenic, hypovolemic, neurogenic. You know the differences. What are the differences? See?
Cardiogenic is from cardiac insufficiency, hypovolemia is a loss of volume, neurogenic is
Fluid volume completely. And
neurogenic is a problem with the neurological reduction.
like the medulla as well. But, yeah. Do you know what anaphylactic is? Anaphylactic shock. What is anaphylactic shock?
The bee stings, allergic reaction.
It's an allergic reaction is what it is, but it's an allergic reaction gone haywire. It's too much. And bee sting is one thing that people can be allergic to in such a state that it can cause their body to overreact. That's the guy who steals a candy bar from the Wawa. They call the police and the SWAT team shows up and the helicopters, right? Snipers on the roof. They overdo it a little bit. It was a
You
Milky
live in
Way,
Missouri?
right?
So they're in communication.
So,
Was that Missouri?
and what about septic shock? Infection. Typically what kind? Typically. In the blood, by what type of pathogen? Bacteria. Right. And you know bacteria can release toxins by a couple of different ways, right? They can either release toxins as a waste product of their metabolism, or they can release toxins when they die. See an interesting reaction with syphilis in patients. and treated with syphilis, you treat syphilis with penicillin. And this often causes these spirochetes to break apart, release their toxins, and it creates a rash. And so, of course, the patients run back to the emergency department, run to the emergency department 6 hours later, saying, I think I was allergic to penicillin because I got this terrible rash. Now, what do we know about allergies to medication, allergies to things like that? When's it going to happen? It's not a delayed sensitivity.
It's quicker.
It's quick, right? If somebody's allergic to something, especially an injection, it's going to happen fast. Even if it's just a rash, it's going to happen fast. And by the way, I think I said this before, every sort of allergic reaction shows up in the skin first. Did I tell you that? Okay, so you see that. So that's why with penicillin, a lot of people have allergic reaction to it, but like 99% of those allergic reactions are just a rash, but you still don't test it, right? You still don't go, he's probably fine, let's try it and see what happens. That's why if you go to the doctor and you get an injection of some antibiotic or anything really, oftentimes they'll say, wait here for 10 or 15 minutes because we want to make sure that nothing bad happens.
What's the term for shut?
Cor pulmonale. Have you heard of this?
Is that the old term for right-sided heart failure?
It can cause right-sided heart failure. This one's not familiar? Or not as familiar? Okay. Or if it is, maybe you just need a reminder. This is the result of blood having a difficult time being pumped through the lungs. There's some sort of restriction. The lungs are in a diseased state of some kind that's causing difficulty for blood to go flowing through it. And of course, that blood coming from the pulmonary arteries and the pulmonary trunk is coming from which side of the heart?
The right
The
side.
right side of the heart. Specifically, which chamber?
Ventricle.
The right ventricle. Which means now the right ventricle has to work harder to push the blood through. And in working harder, like any muscle, it enlarges, but it gets to the point where it is less effective. Does that make sense? Okay. That is a cause of right-sided heart failure. But the most common cause of right-sided heart failure is left-sided heart failure. The left ventricle fails, so stuff backs up. Remember, this is a circulatory system. So if something stops or backs up in one place, it's going to affect the preceding areas. So it will affect all the way back to the right ventricle. Polycythemia vera. Too many red blood cells. What causes this? Idiopathic. Body's just overproducing. Now the problem with having too many white blood cells is like putting too much flour in the gravy. It's going to make it really thick. So now that heart is pumping like if you're on a farm pumping one of those old wells and you hit the bottom and now you're just at mud. It's trying to pump this thicker volume of fluid through, which means the heart's going to work harder. Now, the way to treat this is to actually remove some of the volume of blood. So the patients will go and have phlebotomy done. They'll have blood removed from them. And interestingly, this will show up in men, usually 30s, 40s or so, but it won't show up in women until they're postmenopausal. That makes sense? Because of course they're going to be losing a certain amount of blood on a regular basis. Left-sided heart failure. What causes left-sided heart failure? Well, all kind of things, right? Anything that's causing a backup is going to cause or make the heart work harder. This is where we come back to Larissa's atherosclerosis and arteriosclerotic arteries. Because remember, as that
I
heart...
don't have those kind of arteries.
I'm sorry?
So I don't have those kind of arteries.
You do not, and I apologize for making it sound that way. I don't know if you do, but I'm assuming you do not, and I apologize for that. I meant the example that you had given. Thanks for correcting me again. So, I'm just kidding. You didn't correct me the last time. Pretty much everyone else did. But the heart pumps out the blood, does a lot of the work, But the arteries have to be flexible to accept that blood and then contract to pump it through. So they help maintain the blood pressure that way. So it's a nice cooperation between the heart and the arteries. However, if the arteries stop cooperating, then the heart has to work harder. Does that make sense? Once pressure reaches a certain point, fluid leaks out of the vessels into the lungs. Why? Because it backs up. So it forces fluid out. This can cause the pulmonary edema. Do you see this in patients with left side congestive heart failure? When they go to bed at night, you can ask them, how many pillows do you sleep on, right? Because if they lie flat, what are they going to say? They feel like they're drowning, they feel like they can't breathe, they feel like they're choking. Some people will just say they sleep in a recliner because they can't lie flat at all. If it backs up there, it can back up in the right side. If it backs up there, it's going to back up in other places, like the going through the liver. So it's going to back up. You'll see this abdominal distension. They go back up in the legs. You can see that edema as well. Valve problems. A stenotic plaque is a stiff plaque. Stiff stenotic valve is a stiff valve, which means plaque or something has built up on it. Some sort of vegetations have built up on it. And this is going to cause the valve not to open fully or completely, which means the heart's going to have to force blood through, which means it will have increased the resistance. Insufficient. If the valve does not close completely, blood is going to shoot backwards, which again is going to cause a backup. And the problem with that is if you get blood collecting in an area because of backup, we increase the likelihood, once again, of clots forming. Because what happens when blood stops moving? It starts clumping together. And so I talked about that a little bit with atrial fibrillation, right? That's why we can shoot something up to the brain. Talk about that. Hereditary, one of the most common reasons of atherosclerosis.
And that's because of production or overproduction.
Overproduction. Again, remember, what drug do we use? What's most commonly used for cholesterol lowering? Lipitor. And what Lipitor does is it does not take cholesterol out of the patient's body. It does not block the patient from absorbing cholesterol into their body. Instead, it stops the production. It's at the rate-limiting step, so it won't produce as much. And it works really well. It's very, very effective. Okay, you see the plaque building up. Notice the intima, the endothelial layer. This part of that can get pulled away. Blood can move up underneath it, cause a type of an aneurysm called a dissecting aneurysm. An infarction, we know what a myocardial infarction is, right? Okay, infarction is an area of dead tissue. A myocardial infarction is an area of dead tissue in the heart. And why is this tissue dead? Because it wants oxygen. Same thing with the brain. Ischemia is a restriction of blood flow to an area. Ischemia can cause an infarction, but ischemia itself doesn't mean there's no blood flow to the area. Aneurysm. The key word with aneurysm that is not on the screen, the key word for aneurysm is a ballooning effect, where a part of the artery balloons out. The problem with this is it's going to happen in arteries that are under high pressure. So we see this in the aorta, and we also see this at the base of the brain where the carotid arteries come up, and they sort of meet this group of arteries with the vertebral arteries. They meet this group of arteries and create a little circle called the circle of Willis. So we can see aneurysms occurring there as well. Now, the problem with like an abdominal aortic aneurysm, you'll see that abbreviated as AAA, you'll see that sometimes. The problem with abdominal aortic aneurysm is when it ruptures, we have a lot of blood that's going to dump inside of the body. This is bad news because you literally have to cut them open, grab a hold of the aorta above the tear with one hand, and keep the heart going with the other. Survival rate, once that occurs, is very low. You're not doing that, no. I'm going back to jail, aren't I? That one's going to send me away for sure. Dr. Stroop said, cut open your patients. Grab a hold of their aorta.
Aren't a lot of aneurysms common at junctions, though, also?
Yes.
Where it's already
That's
naturally...
where we see it in the circle of Willis.
Yeah,
at the
that's where
junctions.
my wife says.
Yeah. And a lot of times this happens in patients with high blood pressure, especially elderly with atherosclerosis, arteriosclerosis as well. But there's a hereditary component that can happen. And there's sometimes, in fact, they're often not caught. A lot of the times, they are found one of two ways, either because of a rupture, because of a tear, or they're found incidentally. They're looking for something else and they find this. The ones around the brain, they might be a little more symptomatic, and they start looking for things like that as well. But unfortunately, a lot of these things, they just happen, and people don't realize they had it, and that thing, once that tears, that's bad news. The dissecting one is where part of the intima actually gets torn up, and so blood goes underneath, so it actually tears away one other layer of the artery, makes the wall that much thinner.
What kind of symptoms do they have?
You know, they can have, especially with the head, they can have headaches, things like that. In the abdomen, or in the thoracic cavity, they can complain of chest pain. They can compare of a tearing or ripping pain in their chest. Yeah, they can complain of back pain.
Pulsating mass and
In some patients, it depends on how much mass they have on top of the pulsating mass.
Is there a reason why we hear about abdominal more? Is it more common or just more?
I don't think so. Actually, I think the ones found in the circle of Willis are more common, especially in elderly. But a lot of times they don't do anything for them because in those older patients, it's more risky to actually try and change something. So my guess is it's probably more common there, but you know, you hear about the aortic ones too, the big ones. A ballooning out. You ever hear somebody talk about ballooning out? Good thing. Myocardial infarctions. Symptoms of a heart attack: chest pain, chest heaviness. This, what do they say? It feels like there is an elephant sitting on my chest. Diaphoretic, right? They got sweat just pouring off of them when they don't need to. Shortness of breath, dizziness, and of course, past history. You often hear patients, you'll know it, you know that. So patients, you know, they'll say, this feels like my last heart attack, or this doesn't feel like my last heart attack. Well, this is a new one. Chewing aspirin, what does aspirin do? Is it going to break up that clot? No. It's going to help prevent it from getting worse. And how long is it going to have an effect on that platelet? 7 days. That's a lot of platelet. It's an ambulance. Normal dysrhythmia, normal sinus rhythm. That's a new category. Yeah, normal sinus rhythm. That's totally unusual. Believe me. I was going to say, because you don't see it anymore. That looks like a lot of really good animation that I have no access to. Secondary polycythemia. A lot of red blood cells can be produced by other things for other reasons. For instance, staying in an elevated area for any sort of, for a long period of time, the body will produce more red blood cells because it has more difficulty, has more difficulty attaching the oxygen to the hemoglobin. So it just says, well, we need more red blood cells and we got to get more oxygen. It's interesting because those extra red blood cells can be effective in maintaining oxygen supply to areas like muscle. Why do you think those, like Kenyans, who win the marathons every year? They train in elevated areas when they come here and they have these extra red blood cells. That's why, you see these other people are in the 21st mile barely getting along and they just run on and smile.
They're already done by the point.
Yeah, I was going to say
They started.
they started late. They had coffee and donuts. Lucky guys. Anemia. Here's a problem I have with anemia. I don't have a problem, but other people have a problem with anemia. A lot of people think anemia is a disease. Anemia is not a disease. That's like saying a fever is a disease. It's not. It's a sign of something, right? Now, just because some diseases have anemia in their name, sickle cell anemia, that particularly is a disease, just like yellow fever is a disease, but fever itself is not. So anemia can be caused by a lot of things. It can be caused by insufficient red blood cells, insufficient number of red blood cells. It can be caused by small red blood cells that aren't working properly, or too big red blood cells that definitely aren't working properly. You see that in like folic acid deficiency. Small red blood cells, the microcytic anemias, are things like iron deficiency, or there's a very common, by the way, iron deficiency anemia is very common. Lead poisoning, another reason. But thalassemias will cause a microcytic anemia. Anemia of chronic disease, you see it in things like rheumatoid arthritis or systemic lupus erythematosus, systemic lupus. But iron deficiency anemia, women get this a lot. And unfortunately, the #1 cause for iron deficiency anemia in women under 40 is what?
Not even me.
Dietary. Yeah, they're not eating enough foods giving them their iron. A lot of people will still say, well, it's because women menstruate and they lose. That's not the reason. It's because they just aren't eating the foods with their iron. And we talked about this way back, I think in the early couple of days. When somebody takes foods with iron in, even those cereals that are fortified with iron, remember this example? What do they want to take with the iron?
Orange juice.
Vitamin C, orange juice, vitamin C, because iron's not absorbed well without it. And this is one of the few things, by the way, it's absorbed in the duodenum. You know, not a whole lot gets absorbed in the stomach, other than alcohol and aspirin. Not a lot gets absorbed in the duodenum. Some stuff gets absorbed in the jejunum. Most stuff gets absorbed in the ileum. But iron is one of those things that gets absorbed in the duodenum. All right. We can also have hemolytic anemias. In other words, red blood cells breaking apart for whatever reason. We see that in DIC composite, disseminated intravascular coagulation. You can see red blood cells breaking apart, fragmenting. So anemia itself is not a disease. So when a patient tells you, I have anemia, that's not enough, because how are you going to know how to treat it? So you need more information than that. It will, however, have obviously some of the same signs and symptoms. They're going to be pale because they're not delivering as much oxygen. There's a good trick to do. Do you ever see a trick with a gold ring?
Yeah, it's a black one.
It's a black mark, yeah. If you get a gold ring, you find somebody with pale skin who's anemic, they say they have anemia. Get a gold ring, has to be gold, not like white gold. And get it and just push it on their face a couple of times. And you'll make these nice little black lines on their face that won't rub off. It's not dirt. This is a molecular exchange of something, the binding material with the gold ring to those empty spaces where iron could be. It's pretty cool. It'll last for weeks. No, it won't last for weeks. It'll go away in a few minutes. It won't get in trouble. But assault. Just wear a gold ring and say, oh, it's okay. You'll be fine. Okay.
Now work through your gloves.
Man, I am going to jail. I'm sorry?
But we have gloves on because of Ebola.
Don't you have you wear your gold rings outside of your gloves? Everybody knows that. How else do you see your bling?
You get bling.
Stop it. You're being mean again. plenty of time to be mean to me. That's time. Thanks, we got a timekeeper here. All right, and go! I'm just urging with the sweater vest. All right, sickle cell anemia. We talked about this one already. Sure, right, okay. Remember, the red blood cell should be that flattened donut shape, that biconcave disc that should be flexible. It has that shape because of the globe shape of the hemoglobin molecule. If the hemoglobin molecule changes its shape, which it does because of one change on the DNA strand, one letter change, valine glutamic acid on the DNA strand, that causes the beta chain of the hemoglobin to be more straight, which causes the whole hemoglobin molecule to be straight. And all these straight hemoglobin molecules stack up on the side of the red blood cell, gives it that nice sickle shape. Problem with that is it's not flexible enough to move through those tiny capillaries, and things back up. That's what we call vaso-occlusive crisis. Which, of course, now we have tissue that's waiting for oxygen. Remember, arteries are specific. They have to take blood somewhere. So we have tissues waiting for oxygen. It's not getting it. Those cells are going to start calling for help, and they want to get your attention. So your patient's going to have pain, not you, them. Now, did we talk about why the cell's sick? Why people have sickle cell to begin with? The benefit of sickle cell anemia?
Because of malaria.
Malaria, yes. Plasmodium falciparum, Plasmodium vivax, Plasmodium malariae. All these organisms go into the red blood cell to evade an immune response. It's pretty brilliant. You know, if you want to go into a human body and mature there, but you don't want to get attacked, go and hide in one of their red blood cells. That's what they do. Except they do it by the millions, of course. And then all of these mature at the same time. They all break out at the same time. We have a hemolytic crisis all at the same time. That happens in a small child. No, reverse that. If a small child with normal hemoglobin gets this inside, small child with normal hemoglobin, normal red blood cells, has this happen to them, that can cause them to die. And if they're dead, they're not going to procreate, which means their genes aren't going to get passed along. But the child who sells sickle, if they get bitten by the same mosquito, with the same, the Anopheles mosquito, with the same pathogen, it will not get into the red blood cells. It will not be able to mature. It will get destroyed by the immune system. Those children live longer. They procreate. They pass on their genes. That's why in some areas of the world, you see these large groups of people with sickle cell anemia, because those are areas that are endemic to this organism. Pretty brilliant. Well, they don't know that. They don't know that. It just worked out that way. Oh,
I mean, the virus doesn't have a brain.
Sorry? This is a parasite. Okay, shoot. Leukemia. Man, I didn't want to do this yet. We're doing the lymphatic system on Saturday, yes?
And there's a lot more
On leukemia. It might be on the test. Very quickly, leukemia. Here's the problem with leukemia. If you ask people, if you ask nurses, what is leukemia, they'll all tell you the same thing. In fact, what is your definition of leukemia? Disease affecting white blood cells. How about cancer? Better, cancer of the white blood cells. And then what about it?
It's
Okay.
really bad.
Yeah, that's the entire definition of leukemia. Cancer of white blood cells, it sucks. Yeah, I'll put that on there too. Here's the problem with leukemia. The directions on how to make these white blood cells, the directions are wrong. The body realizes it's running low of a certain type of white blood cell, so it sends an order to the bone marrow to make more of that particular white blood cell. So the bone marrow follows the directions that it has, and makes more of these wrong white blood cells and ships them off into the blood. Well, they look different, and they don't do what they're supposed to do. So the body says, where are those white blood cells I ordered? All I've got is this other garbage. So it puts in another order for white blood cells, that particular type. So the bone marrow makes more of that particular type. And it releases them into the blood, but they're still wrong. And we end up with blood that is full of all these white blood cells that don't look like they're supposed to look and don't do what they're supposed to do. Meanwhile, because the bone marrow has been trying to keep up with that production of other white blood cells, like the lymphocytes, for instance, and the eosinophils, for instance, starts to go down. Now they have white blood cells that are wrong, they're not doing what they're supposed to do, so they can't fight off the infections they're most specific for. We have other white blood cells that are low, because the bone marrow wasn't able to keep up production of those, because it was working overtime to do these other white blood cells, so they can't fight off the infection of those. So now we have people who are getting chronic infections. Does that make sense? So the only way to fix this is by changing the directions in the bone marrow. Well, unfortunately, we don't have the technology yet to go in and just change that one page of directions. So instead, we have to burn the whole book, or burn all the files in the filing cabinet. And then we have to refill the filing cabinet with directions that are correct. And that's what we call a bone marrow transplant. So if it sounds messy, I like to use the term burn everything. You burn the book, you burn all the files in the filing cabinet, because if it sounds messy, it is. You end up with, you know, a lot of tissue that is destroyed that shouldn't have been, a lot of side effects. But that's how you fix that. And of course, we're never going to get an exact duplicate, right? But we want something close. We're never going to get an exact match. We want something close. Because if there's a huge difference in the type of antigens, then the antibodies are going to attack them. Remember, the bigger the difference, the bigger the attack. So what we do is we find something as close as we can, so there's a smaller difference. Smaller difference, smaller attack, that we can suppress. The patients have to stay on medication to suppress that. That's leukemia. Lymphoma is very similar, except instead of being all throughout the blood, it's going to be in one mass, one area. And the problem with this is some of the lymphomas can become leukemias, and some leukemias can look like lymphomas. So it gets confusing. I'm sorry.
They take all of your red blood, bone marrow out of your body? Or is it only certain sites?
Certain sites, but I don't know which sites they use more than others. That I don't know. Leukocytosis, white blood cell count is high, probably for a reason. This is why we do a CBC, right? This is why we want to see all those different ones. And leukopenia, not enough. Penia is a decrease or a lack of something. So leukopenia or leukocytopenia. One reason that blood doesn't clot properly is hemophilia. Hemophilia is a type of disease that actually interrupts the blood clotting cascade. There's a couple of different areas, hemophilia A, B, or C. Hemophilia B you might hear of sometimes as Christmas disease as well. But there are other reasons why blood doesn't clot properly. Anything that's going to cause a problem with the thrombocytes will cause that to happen as well. Von Willebrand's disease is another one you might hear of. Glanzmann's thrombocythemia is another one you might hear of. Thrombocytopenia, not enough thrombocytes. What's a thrombocyte? It's a platelet. Thrombocyte is a platelet. It's a cell fragment. Is there any DNA in it? It's a cell fragment. Okay, there you go. Well, that's a good image of the aneurysm rupture. Bad news bears right there. We'll talk more about the lymphatic system on Saturday. The difference between the cardiovascular system and the lymphatic system, cardiovascular system is a circular system, right? It always goes around. The lymphatic system is a one-way system. It starts in the capillaries, collects fluids, collects cell particles, and then gets filtered through things like lymph nodes and some of our lymphoid organs, and then is dumped back into the blood just before entering the heart. But we'll see that one later on again. Okay, there we go. If blood is in the right ventricle, where did it just come from? What valve did it just come through? What valve is it about to go through? And into what vessel?
Pulmonary trunk. And then the pulmonary artery.
Pretty close. All right, ready for a break?